Поехали. Okay, thank you very much for your attendance. Let me introduce our research. Okay, so as you know, artificial intelligence is now taking a big part of our lives, integrating in every life part, and IVF is not excluded from that. As embryologists, we are both embryologists, so we have to choose the best embryo, which has the best potential to give pregnancy. And so we have to improve pregnancy rate per embryo transfer, resulting in the faster pregnancy for the patients without any economical or emotional burden. And so most of AI models, they rely on embryo performance on time-lapse imaging. So sometimes they use morphokinetic parameters or only a blastocyst stage, but all of those, they result in some embryo scaling, giving the score for embryo, thus resembling the potential for implantation. So every model needs some sample size for training. So there is some minimal sample size, but still, if we increase the sample size, there is no advantage in accuracy for those models. Strange. And we have some recent study in Fertility. The authors, they explored 50 AI models for embryo scoring. And they tried to analyze the same embryo with all those models. So they found out that in the same embryo, different models pay attention at different parts of embryos. Sometimes the parts are out of the embryo itself, but still they give the same score for those embryos, a similar score. When we analyze embryos, some different embryos, we expect some cohorts like a prospective cohort, some good quality embryos, and some poor prognosis embryos. But in the study, the authors showed that there are no cohorts for them. So we tried to develop our own model based on only static images of blastocysts. Well, we used the neural networks that are commonly used for time-lapse imaging. And so we demonstrated almost the same thing, that different models pay attention at some different points of interest in embryos. So they are not so stable. Thus, there are some models that are more stable and they pay attention at similar points of embryos, but they lack accuracy.
Okay, then my part of our study, Iullia mentioned that yes, we established several models, and as for us, as for humans, it's understandable that we want to see something, but with pre-existing neural networks, sometimes it's, I couldn't say impossible, but sometimes we have different results, and the main point of that, we have the table when we summarize different combinations of different neural networks. Some of them pre-built for analysis for images, some of them are for patients and laboratory data. And we observed that introducing this part of embryo recognition, introducing the part of imaging of the embryo does not increase the ability of the neural network to predict the right chances of pregnancy. So we combine them with our model that we reported in the previous meeting and observed that we have the same results with embryo specificity and without it with tabular data. So what we did next we want to combine our previous work with different neural network structures in one pipeline for analytical approach in embryology and embryology data inside the lab. and we introduce NVCI approach for strict rules that we have inside the laboratory, and introduce embryo imaging inside this pipeline. And finally, we can see that we reach the same scores of model productivity as ROC-IUC curve and precision recall curve higher than time-lapse imaging. So it means that existing models have different approaches and have strict reproducibility in different cases, in different countries, in different situations. And without proper calibration inside individual lab, we cannot expect proper function of existing AI models. And sometimes raw tabular data from the laboratory is the same accurate than existing time-lapse complex models that requires additional equipment, additional costs, and additional time for annotation of embryo development and previous patient's history. So what is the practical implementation of our pipeline? This is the table of summarizing this. We can establish not only the threshold KPIs values that we can introduce in our quality control part of laboratory or quality control part of patient care. We can understand what are the minimum number of blastocysts, what are the minimum numbers of 2PN zygotes for successful pregnancy we should have, or we can understand what the levels of our performance we can achieve to say doctors, to say our directors that we are working well. Then we can introduce those pipeline for establishing minimum criteria for guarantee IVF programs. For example, when we want to have at least 2 or 4 euploid blastocysts for transfer to be sure that we will have a pregnancy in this cycle, we can establish those minimum criteria with our neural network pipeline. And something new that we did, we want to analyze those clusters. As Iullia mentioned, some recent studies show that there are no clusters, no groups of embryos that we can recognize after AI prediction. But in our model with laboratory KPIs data, we can show those clusters. For example, we can divide our cycles to good prognosis and bad prognosis for future pregnancy. And we can introduce 3 clusters with good prognosis, moderate prognosis, and poor prognosis cycles. And then we can go to the prospective research when we can have a prognosis for a next cycle. So we can introduce a new patient in our pipeline and understand before the treatment, before the result, what we should expect in this cycle. So we can not only consult embryos, but we can expect from something from the laboratory, from this treatment cycle, and usually we expect good results, yes, but with this AI approach, we can see that sometimes it is not good results, and we should have additional attempt, or we should not be so proud when we have good results and not so disappointing when we have bad results according to this prognosis. Of course, all those models are very not very similar and depends on multiple parameters. And if we establish different number of clusters, if we want to look deeper inside, we should have additional data analysis of our distribution of data, also with images, also with laboratory parameters and KPIs. And we can see that different number of clusters can describe our data in different ways. And this is a very important thing, because sometimes with different methods, we cannot find any clusters and any different distributions in our data. But for example, with the k-means, we can find it and significantly divide our parameters in several classes and for what I saying that sometimes we can trust AI systems. Sometimes it is impossible. It depends not only on data quality, but it depends on how we understand our data and how we prepare it. And it's very important of which model we use and what we expect from this model. The main thing after AI implementation is interpretation of what we had as a result. For example, with 3 clusters, we can understand that we have clusters of cluster 0 good prognosis patients, cluster 1 of bad prognosis patients with each KPI values here, and green cluster with moderate prognosis patients. We can understand that sometimes we have grouped patients independently of our knowledge, independently of our data and our basic knowledges, according to age groups, according to donor or PGT cycles, and with unsupervised machine learning, we also can recognize different clusters inside our data and understand where our patients belong to for good prognosis, moderate or poor prognosis. So at the end, what those clusters help us to understand, they help us to understand what to expect, as I mentioned in our study, and it helps us to observe our data. So in our data, we find out that age distribution is the main factor of success in IVF. Mother's age is the same among those clusters, but we have different distributions of KPIs in pregnancy rates in different clusters. And we can find out that in different ages, in different clusters, we can have different stimulation protocols, different number of IVF attempts, and different strategy for those patients for the future treatment optimization. And from these observations, we go towards clinical insights, towards what we should improve to work better. This is the main goal while we're working with AI solutions, while we're analyzing our data. And we can see that we can have different strategy, for example, for stimulation protocols in different clusters of patients. We can have different results of those stimulations, and we have different observations of the embryology parameters inside those clusters. So we also can validate different treatment strategies with AI solutions and understand that sometimes we should have higher dosages of stimulation to obtain the same number of oocytes, same number of blastocysts, sometimes not. And that's why I'm talking about AI, that in IVF we have different protocols for different patients groups. We have criteria like Poseidon criteria, like Weiner and Maribor consensus criteria for embryology and reproductology spheres. And with AI solutions, I cannot say proof. I can say that we see the same results as our experience inside of more than 40 years work in IVF have the conclusions that those patients need this strategy, those patients with poor ovarian reserve have the same strategy. And the main advantage of AI solutions that we can build our own criteria inside our own clinic with appropriate data augmentation and implementation inside the lab and inside the treatment cycle to be sure that we don't like the followers of some clever people of the world, but we have our own understanding and we have our own presentation of our patients, our stability in parameters and our values of KPIs that we should trust inside our own laboratory. Thank you very much for your attention.